Hello, good morning. Can you hear me now? Yes? Good, good. Uh, अच्छा ये मेरी वीडियो देख रहे हैं Start video, okay. I thought, while lecturing, you should see me as well. I can't see you, but at least you should see me. I hope you're doing fine. Oh, good morning, good morning. Yes, yes. Yes, we can hear you. Right, okay. I hope you're doing fine and studying hard. Also, pray to God, Allah Almighty, कि ये जो जान छूटे ये COVID-19 से as soon as possible so we can see each other in person. Right, okay. Well, here we go. Let's start. Get going. I hope you're praying and studying at the same time. Uh, well, today's topic is pretty important, from surgical point of view. Usually a question is asked about pancreas gland and the important topic, I think the university questions, which is usually asked is, okay, thank you. All right, okay. All right, you stay around. Can you stay around? Yeah, okay. Because some time goes on, so we need somebody. Yeah, okay. Right. So the important questions usually about pancreas gland uh, is acute pancreatitis, the presentation of a patient, usually middle-aged person, comes with severe upper abdominal pain, and the usual hint is that the pain refers to the back. Severe pain, severe upper abdominal pain, and the pain refers to the back. And they also give laboratory investigation like serum amylase. It should be in thousands. The normal serum amylase is between 100 and up to 300. But if the serum amylase is more than that, usually in pancreatitis is in thousands. So you should be able to diagnose it that this is a case of acute pancreatitis, right? Now, the other important question in this uh, gland is a carcinoma of the head of the pancreas. Okay, so usually there's one or two questions. As you know, pancreas gland, you should know something about pancreas gland. As you know, pancreas gland is an exocrine as well as an endocrine gland. This is a gland which has got both the components. Exocrine means it secretes all its enzymes into the pancreatic duct, and that opens into the second part of the duodenum. Right? This is a very important diagram, and you should visualize it and keep it in your mind because it gives you quite a lot of information. Now, this is the pancreas gland. Okay. Now, this pancreas gland has got a head, a body, and a tail that abuts onto the hilum of the spleen. And there is this process, is called the uncinate process, that comes down from the head and goes in between these mesenteric vessels and the pancreas gland. So uncinate process, head, body, and the tail, which goes right down to the hilum of the spleen. Now, as you can see, this is an anteroposterior view. You imagine a man is standing in front of you, and the stomach has been removed, and then what you can see is these great vessels, the aorta inferior vena cava at the back of the pancreas. These are all retroperitoneal structures, okay, except spleen, right? Kidneys are retroperitoneal, uh, Pancreas, the whole pancreas gland is retroperitoneal. The great vessels are retroperitoneal, and behind these are the vertebrates, the vertebral bodies, and the great vessel, and this pancreas gland. Now, if you just look at this, that these veins, splenic vein, this is a very important thing to remember. Splenic vein and the superior mesenteric veins, they open into this portal vein. Okay, they open into the portal vein, and that portal vein goes into the liver. Now, what happens in cirrhosis of the liver? Imagine there's a liver there. In cirrhosis of the liver, there is a blockage of flow of this portal venous blood into the liver. So there's a back pressure. So there's a portal hypertension. The pressure in the venous blood that goes high in the mesenteric vein, and also in the splenic vein. So what happens in portal hypertension? You get splenomegaly, and you get high portal venous pressure will cause ascites. Okay, and you can see these kidneys at the back, spleen there, and all these vessels. Now the next slide, right? Now that's the pancreas shown right from the tail, the body, the head, and this uncinate process. I hope you can see all these very clearly. Can you? Right. Okay. So now the very important thing. Can you see this is a pancreatic duct bringing all the exocrine enzymes. Now the exocrine are the one which are secreted, and through the duct they open into the second part of the duodenum. Now there are four parts of duodenum. First part, the second part, the third part, and the fourth part which joins the jejunum at the duodenojejunal flexure. Now the important thing to remember here is that pancreatic duct, when it reaches there near the duodenal papilla, the CBD, it joins with the pancreatic duct and they form a common channel. And then it opens through that common channel into the duodenum through the sphincter of Oddi. Right? Now, can you see these small little stones coming from the gallbladder through the CBD right down here, and they're blocking the common channel, right? And when the common channel is blocked, all the secretions from the pancreas gland, I'm telling you the pathophysiology of pancreatitis, that is inflammation of the pancreas gland. How does it occur? So if there is a blockage here, there's a back pressure, okay, back pressure into the pancreatic duct, and all these enzymes which are not in active form, they become they are activated, and they cause autodigestion of this pancreas gland, right? At the same time, this can also, this stone, if it's completely blocking the CBD, that will cause the obstructive jaundice as well. But most of the time, the pancreatitis, the stone stays there, causes a pancreatitis, and usually they are small stone, it passes on. So one of the causes in the etiology of acute pancreatitis in Pakistan is probably the most common is the gallstones. especially the small gallstones. They're very notorious to cause pancreatitis. So if you see anybody with this ultrasound scan showing multiple small gallstones, then you should advise them to have a cholecystectomy. Otherwise, small gallstone can come in, block the pancreatic duct, cause a pancreatitis, and pancreatitis is a serious condition. It has got uh, serious morbidity and mortality. So we should try to avoid it. Okay. Now, in addition to the exocrine part, the pancreas gland also got endocrine elements, and the endocrine elements are, for example, beta cells. They secrete insulin. Alpha cells secrete glucagon, and delta cells secrete somatostatin and pancreatic polypeptides, other hormones. Now, these endocrine part that goes directly into the bloodstream. So that's the endocrine system. It doesn't come to the pancreatic duct. These are the enzymes. The exocrine part is always these enzymes are secreted through the duct. The endocrine part, it goes to the circulation. Okay, and this, for example, this insulin goes through the portal vein and then affect the rest of the body. Okay. So that's very important to understand. If you know the anatomy a little bit, then you can actually find out what causes. Now, the activated enzymes, which are normally activate if there is no obstruction, all these enzymes, they go into the duodenum, and there is enterokinase, and that activates it so that the all food stuff can be digested. Okay, but if there's a blockage there, and there is some reflux of some enteric juice or the duodenal juice, that's reflux, and that activates it, and that activated enzyme cause autodigestion, inflammation of the whole pancreas gland. It can be mild, what we call mild pancreatitis. It can be severe pancreatitis with very high morbidity and mortality. Severe pancreatitis patients, you treat them in an intensive care unit or CCU, whichever is available in your hospital. You can't treat severe pancreatitis in the ward. But mild pancreatitis can be treated in the ward. Uh, we'll come to the treatment when we agree to that. So one of the causes of pancreatitis is gallstones in Pakistan. But if you go to North America, in France, and in Europe, in England, you see alcoholic pancreatitis. The alcohol is the major etiological factor that causes pancreatitis. Okay, so what are the other causes that can cause pancreatitis? For example, nowadays we're doing quite frequently this endoscopic retrograde cholangiopancreatography, ERCP, from the stomach into the duodenum. The scope comes down and you dilate this papilla, you manipulate it, and because of that manipulation, you cause some inflammation in that. So, post ERCP, anybody who has ERCP, you should be watching them because quite a few develop this post ERCP pancreatitis. Okay, so gallstones, alcohol, post ERCP, any surgical operation like spleen, stomach, or any other duodenum, post-operative you can have pancreatitis too. Then there are other areas where you can have pancreatitis. For example, viruses. For example, mumps and coxsackie B virus can cause pancreatitis. Okay, and certain drugs like steroids, corticosteroids, sodium valproate can cause this trauma during surgery, or blunt trauma can cause severe pancreatitis. So the uh, proactive uh, enzyme gets activated and starts eating, auto-digesting the pancreas, is a pretty serious condition to have. And there's a lot of fluid, as it this pancreas in the retroperitoneum, there's a lot of fluid, sometimes blood stained, that can collect in the retroperitoneum in third space. So you lose quite a lot of fluid in the third space, not in the intravascular compartment. So the blood pressure goes down, patient is cold and clammy, sweaty, low blood pressure. So you've got to give them a lot of fluids, like sometimes 3 to 4 liters, in just few hours, for 6 hours. So to bring the blood pressure up, so that the kidney functions are not compromised, because the people die of renal failure. There are so many other factors considered with the pancreatitis. Is basically not a disease of just the pancreas gland. You can have pleural effusion in the lungs following pancreatitis. You can have, MI, myocardial infarction following pancreatitis. It is suggested that probably some myocardial depressant factor is released following this pancreatitis that acts on the myocardium, and the patient, they came with pancreatitis, died of MI. So, it's that kind of, so it's more of a syndrome. It involves multiple systems rather than just the pancreas gland. Right. Okay. So that's the you should understand where the head of the pancreas fits into this sea of the duodenum. Okay, and the body and the tail of the pancreas. Right. Okay. So we'll go to the next slide, please. Yeah. Oh, where's the next slide? Right. Okay. Now, if you look at that, there's a test tube which contains a blood-stained liquid. So that's the kind of fluid that exudes out of the pancreas gland. It's a hemorrhagic pancreatitis, and also just look at these white spots. These are fat necrosis. You know what happens is the lipase uh, 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 from the is released from the pancreas gland into the circulation. When it gets in touch with the fat of the body, it converts into this fatty deposit. When it joins with the calcium, they form these calcium soaps. It's called calcium soaps. So if you do the investigations, and you'll always find in pancreatitis the serum calcium is low, because that is used in the formation of these all over in the peritoneum, these little white spots. Okay. Now, what are the other causes it can cause pancreatitis? Before I go on to these other causes, I would like to mention that because of this pancreatitis, there's a lot of hemorrhagic fluid in the left hypochondrial region, in left flank. It collects subcutaneously and causes sometimes bruising on the left side. So if you look at the clinical method, sometimes they say that in acute pancreatitis, severe acute pancreatitis, you can see bruising of the left flank. And if you see that, it's called Gray Turner sign. So you examine the patient, it's very tender in the upper abdomen, and you can see Gray Turner sign. That means the bruising on the left side is because of the collection of this hemorrhagic fluid. And sometimes the hemorrhagic fluid collects around the belly button, around the umbilicus. It's called Cullen's sign. So two signs clinically you should remember. colon sign around the umbilicus. If the hemorrhage collects together, give discoloration. If it collects in the left loin, it's called gray Turner sign. They are pathognomic of pancreatitis. Right. Coming back to the possible etiological factors, we've discussed about how gallstone causes pancreatitis, alcoholism, that's a known factor worldwide, post ERCP, after ERCP following manipulation of the papilla vater, of duodenal papilla, sphincter of Oddi is damaged, and that causes pancreatitis. Then any abdominal trauma could be surgical, uh, or could be blunt abdominal trauma following any surgery, gastrointestinal surgery, biliary surgery, cardiothoracic surgery. Patient do have post-operative pancreatitis. If any ampullary tumor, ampulla vater tumor causes obstruction and can cause the pancreatitis. There are certain drugs, as mentioned, corticosteroids, azathioprine, asparaginase, valproic, thiazide diuretics can causes dehydration, and that leads to pancreatitis. Then estrogens can give rise to uh, pancreatitis. Hyperparathyroidism, hypercalcemia can cause pancreatitis. Pancreas division. Right, before I go on to this, if you look at this, the pancreas, the spelling of pancreas, I remember last time in the last class, nearly half of the class wrote down the spellings of pancreas as pancreas. They put E at the end of pancreas. So try to avoid that. Pancreas, spelling is very important. Hello? Ijaz Hussain, are you trying to say something? Don't write, don't write pancreas, okay? Write pancreas. Now, there are autoimmune causes of pancreatitis, hereditary causes, viral I already mentioned, malnutrition, and scorpion bite. That scorpion bite typically causes pancreatitis. I hardly could hear you people. Shazma Sarfraz, I don't know. Excuse me, ये आता है जो इनको मैं इनको सुन सकता हूँ बात इनकी यार ये कोई बात करना चाह रहा हो तो इसको क्लिक कर दूँ तो हो जाएगी बात किससे करनी बात या ये जो आ रहे हैं सारे जी सर अनम्यूट कर देते हैं इसको कर दें इसको सर उधर से होगा अच्छा रहने दो यार फिर ऐसे टाइम वेस्ट होगा ओके उधर से अनम्यूट करें एंड देन that takes a lot of time. Okay, so these are the possible causes. Sorry about that. I can't uh, uh, hear you because you have to unmute it and unmute it back again. That wastes a lot of time. Now, the next is the most important thing is when you see a patient, they come with severe upper abdominal pain, going back to the in the back of the loin or in the back, and raised amylase. Sometimes there is a history of gallstones. So you know it's a gallstone pancreatitis. Sometimes you see gray Turner sign in the loin, bruising in the loin, or colon sign around the umbilicus. It says pancreatitis. But the most important thing, you should try and find out what is the cause of this acute pancreatitis. Okay? Having said that, there is a 20-30% chance that you might not find any cause for the pancreatitis called idiopathic. So up to 20 and 30% is acceptable. Okay? But it's not that a patient comes to you and you straight away put them on idiopathic. No, no. Try and find out. Do an ultrasound scan, okay? And see if the patient got gallstone. Could it be gall stone, because once the pancreatitis settles down, patient is stable, then you should go ahead and do a laparoscopic cholecystectomy. So this should not happen again. Okay? And the patient is alcoholic, try to make him understand, don't drink too much binge alcoholic, and try to avoid it. Okay? And similarly, if the patient's on different treatments, different medication, withdraw those medications. Now, as I mentioned, if the etiology is gallstone, then cholecystectomy is desirable during the same admission. Same admissions mean once the patient is stabilized. Okay, you can't do cholecystectomy straight away when the patient is almost very serious. Once the patient, the pancreatitis settles down, don't send the patient home because he might come back with the same attack again after a couple of days. So try and do sort out the original problem which has caused this pancreatitis. All right. Now, is that clear? Can you hear me now? You can just text, write down if you can hear you, everything's all right. Now, the other important things, apart from gallstones, alcoholism, post-ERCP, trauma, drugs. These are the drugs you should remember that they can cause. And the other areas I mentioned, hyperparathyroidism, hypercalcemia, the calcium blocks the area that causes pancreatitis, and other autoimmune, hereditary, viral, malnutrition. Idiopathic is a very pronounced entity because I think uh, about 20 to 30% of cases of pancreatitis, you don't find any reason for this pancreatitis. Okay, so idiopathic pancreatitis, don't label them straight away. Try to find out the cause, and if you can't find a cause, then probably you can say this is idiopathic pancreatitis. You don't know the reason for this. Okay, now you've got this patient, 50-year-old, come with this serious problem, and you try to examine his tender all over the abdomen, probably peritonitis, and patient is in a shock state with low blood pressure, tachycardia, got cold and clammy skin. You try to manage them conservatively, okay? So the management of acute pancreatitis is conservative management. It's not surgery. Don't ever do that because whenever you try to do surgery, the wound will never heal. All right. So this is one of the contraindications of the acute pancreatitis. Try to manage them conservatively with IV fluids, with the monitoring of intake-output chart, with catheter, and make sure patient is passing enough urine. Enough urine mean urinary output should be above 50 mils per hour. If it's low, that means you're not giving enough fluid. Sometimes you've got to give 3-4 liters in first 4 to 6 hours. Okay. Right. So once you've got these, manage the patient. Sometimes you need, if the patient is vomiting, pass an NG tube, monitor them intensively, blood pressure, electrolytes, look at the serum calcium. Usually the serum calcium is low, so you got to give calcium gluconate. Okay, so once you manage it and slowly patient monitoring comes normal or near normal, then then you start managing the patient and try to find what the etiology and what should be done about it. Right. If you have now, how you can patient come with this severe pain? You don't know what's the cause of this pain. Is it a duodenal perforation? Is it acute cholecystitis? Is it a peptic ulcer disease? Is it mesenteric ischemia? There are so many things that can cause this. So how would you diagnose it? Okay. Usually in a scenario, they give you the values of serum amylase. So to diagnose it, so what you need to do is get the blood test done, send it to the lab for serum amylase and serum lipase. Okay, as I mentioned, serum amylase, high serum amylase in more than 1,000 or in thousands, that confirms. Hello, Usma Amna Tarali. Yes, sometime I can hear some of the students. So serum amylase is readily available, but serum lipase is more accurate. But the problem is it's not readily available. So what we rely on mainly is the serum amylase estimation. If it's in thousands, we know this is a case of pancreatitis. If you're in doubt, you can do a CT scan, but CT scan is not indicated straight away. I'll tell you why. What you can do ultrasound scan just to make sure it's not a gallstones or is there any dilatation of a CBD, any stone, the CBD that's causing the pancreatitis, so it could be gallstone. That can help in diagnosis, the ultrasound scan, okay? CT scan is done to see if there is any complications because of pancreatitis. That's usually done after a week or 10 days, okay? Now, let's go down to the blood tests. Now, you do the serum amylase lipase, and you look at the plasma peak level within 24 hours. Okay. Now, what you see the sensitivity and specificity of both of these. As I mentioned, this is more sensitive and more specific, but it's not readily available, so we rely on the serum amylase levels. Okay. Now, they sometimes the question uh, is a raised serum amylase. Does it always mean that it's a pancreatitis? Answer is no, because there are certain other conditions that can cause a raised level of serum amylase, and if there is any doubt, always get a CT scan done to find out uh, the reason for this raised serum amylase. It's called hyperamylasemia. So there are so many other causes of amylase, but markedly increased serum amylase is usually because of pancreatitis. But if there's a raised serum amylase, it can be from other causes as well. For example, if there's a upper GI tract perforation, for example, duodenal ulcer perforation or gastric ulcer perforation, because of the close vicinity of pancreas gland, there is always some inflammation of the pancreas gland. So even in upper tract perforation, you can have a raised serum amylase. Some of the amylase enzymes they get released into the system, and you can have a raised serum amylase. Similarly, if there's a mesenteric infarction, that one of the small bowel portion of the small bowel, jejunum or something, if there's a blockage of the blood supply to that area, that can part of the bowel can get infarcted. That can cause raised serum amylase. Similarly, if there's a torsion of any intra-abdominal viscous, that can cause, because of reduced blood supply, that can go dead, and there is a raised serum amylase. If it's a retroperitoneal hematoma, that can irritate that can irritate pancreas gland and can cause these macroamylasemia, renal failure. Then uh, if the salivary gland inflammation, because this amylase is also in the salivary gland, so that can give rise to a raised serum amylase. So there are other causes of raised serum amylase apart from acute pancreatitis. But most of the time, if a patient presents with a markedly increased level of serum amylase, it is usually acute pancreatitis unless proved otherwise. Okay, so there we go. Next. Now, the investigations of pancreas gland. In pancreatitis, what you can do is serum enzyme levels, as I said, amylase and lipase. And you can have pancreatic function tests, see which pancreatic functions are involved, then do ultrasound scan to confirm the collection, perforation, or gallstone, CT scan. If there is a doubtful diagnosis, then you can do a CT scan. Okay, MRI, endoscopic cholangiopancreatography. It's example, as you want to know the biliary tree and the pancreatic tree, you can do that. Or if there's a small stone causing gallstone pancreatitis, what you can do is organize an ERCP, remove that obstruction, and the patient will start getting better. The endoscopic ultrasound can be done. Sometimes there is a duodenal tumor at the papilla. It's called papillary tumor. Okay, Hamna, how are you? Good. How's your sister? Is she doing all right? Working in Gujranwala, I think. Right. I hope she's doing all right. Now, coming back to this plain radiography, what do you see in the chest X-ray in acute pancreatitis? What are the findings uh, of chest X-ray in acute pancreatitis? Well, you can have, uh, particularly on the left side, if you look at that, there can be pleural effusion. There is an inflammatory process going on beneath the left hemidiaphragm that can cause this pleural effusion, usually on the left side, but it can be on the right side as well because of low albumin. You can have pleural effusion. So that's the thing you can see on the chest film that will tell you that there is hypoxemia following pancreatitis, and it's because of the pleural effusion. Now, if you look at the upper abdominal X-ray, how does that help? If it's a pancreatitis, you know the C, the duodenal C, there is stasis. It's called the gas bubble because of stasis, because of paralysis of duodenum. You can see stasis of gas on the plain abdominal X-ray. You see gas in the duodenum. So these are investigations for any patient comes with pancreatitis. Now, what do you see in the ultrasound scan? You can see that's, I hope you understand, see that mass in the head of the pancreas gland. Okay, and see the dilated ducts, pancreatic ducts in the body of the gland. So ultrasound scan sometimes gives you information, help in the diagnosis. Now that's a CT scan, that's a plain, unenhanced CT scan. You can see this calcification around the pancreas gland, and there is some fluid collection as well. And if you do a contrast examination, oral and IV contrast, you can see this calcification and some collection in the. Sometimes there is a collection behind the pancreas gland is called a pseudocyst of the pancreas. It can resolve spontaneously, but sometimes it needs a surgical intervention, internal drainage, a cystogastrostomy or cystojejunostomy to drain pseudopancreatic cyst. Okay, these are one of the complications of pseudopancreatic complication of pancreatitis. Okay, right. The next, now, yeah, that's an important thing. You see, if you look at that, there is an area. It's the pancreas. That's the that's the spine. Okay, the kidneys, the liver, and the stomach gas shadow. That's the pancreas beneath the stomach, right down there. Okay, and you can see these uh, veins, pyramids enteric veins. That's the one with the thrombus in it. And this rounded thing is a distended gallbladder. Okay, so that will come up on the CT scan. Now I'll get back to you when we go to that distended gallbladder in CA head of pancreas when we reach to that. Okay. Now the other is sometimes there's a tumor, insulinoma. That's the endocrine tumor of the pancreas gland. You can do local excision, and the patient can go back to normal blood sugar levels. Now that's the another is the MRI. If you look at that, you see this the CBD. That's the gallbladder. That shows stone, the neck of the gallbladder, and there's a stone there, the lower end of the CBD. Okay, that causing blockage is causing obstructive jaundice because of stones. It's usually painful obstructive jaundice because the movement of the stone. Stone causes pain. See? But at the same time, you get a painless jaundice, then you start thinking about carcinoma of the head of the pancreas gland and the law which says in a painless jaundice in a patient with a jaundice, which is usually painless, if the gallbladder is palpably enlarged, it's a distended gallbladder, and this patient is jaundiced, no pain. It is almost always due to carcinoma of the head of the pancreas. It's called Courvoisier's law, C-O-U-R, Voisier's, V-O-I-S-I-E-R-S, Courvoisier's law. Usually they ask, sometimes during Viva or sometimes write short note on Courvoisier's law. Okay, maybe one of the part like C part or D part. Now, if you look at this, that's the ERCP. You can see that scope, endoscope, and that's the catheter comes out. Okay, and that inject contrast. It's called endoscopic retrograde pancreatography. You can see this pancreatic duct is visualized. All right, and there is also a duct of Versing and Santorini, the two ducts, developmental ducts, duct of Santorini and duct of Versing. That's the contrast in the duodenum itself. Okay, so that's actually something normal just to see ERCP showing pancreatic duct and the ducts as well. Okay, now another picture. That's the ERCP, and if you look at that ERCP, the catheter, and you can see this a malignant structure. Okay, in the lower end of the common bile duct. You look at this on this picture, that's the CBD, and that's the stricture here. Okay, so this is stricture here. You can see the stricture in the pancreatic duct. This is called double duct sign, the two strictures, bile duct, pancreatic duct strictures. And these are typical of a malignancy, double duct sign, usually a malignancy of the carcinoma of the head of the pancreas. Okay. Right. Now, external injury to the pancreas can be from surgery, from injury to the other organs. Pancreatic duct can be disrupted. Sometimes fall can crush the pancreas gland against the vertebral bodies. That can cause a disruption of the pancreatic duct and can cause pancreatitis. Okay, if it's a severe pancreatitis, it can cause necrosis. Now look at this: is black, charred pancreas gland. Most of the time, it's mild pancreas. There's no necrosis. Okay, but if it's and sometimes it's about 10% sterile necrosis. There's no infection there. This is the retroperitoneum confined areas. There's no infection, but it can be an infective necrosis that leads to an abscess formation and surgical intervention. Most of the time, you deal with pancreatitis conservatively, but if you develop some necrosis, abscess, then you have to either drain it percutaneously, or you have to go in and remove or drain the abscess. Okay. Now, these are the usually queries. Yes. Okay. Somebody's trying to speak. I'm not getting who's speaking and what you're trying to say. So let's just limit ourselves to this presentation then. So what do you think about amylase and lipase? As I said, lipase is more accurate, but it's not available. It's not readily available. So we rely on serum amylase. Now, what about ultrasound and a CT scan? Well, ultrasound, initially, that will give you the gallstones, which may be the cause of pancreatitis. CT scan is not done immediately, but if there is a diagnostic doubt, then you can do a CT scan. If you're not sure whether it's a perforation or pancreatitis, if you're not sure whether it's ischemia of the gut or pancreatitis, then you do a CT scan. That can help. Okay. Now, why the patient should be kept in ICU or in the ward? Well, if it's a mild pancreatitis, you can treat the patient in the medical ward. But if it's a serious pancreatitis, severe pancreatitis, then treat the patient in ICU. Now, there's always a controversy: should we give them enteral nutrition, because the patient stays there in the ICU for 7 to 10 days, sometime more, and the patient is without any nutrition. So should we give them enteral nutrition, or should we start them on TPN? There's always a controversy and some pros and cons of these two schools of thought. But some patients say that as long as the patient is not vomiting, enteral nutrition can be encouraged. Or if the patient is not responding, then you can put the patient on TPN, give them nutrition. Antibiotics. If there's severe pancreatitis use antibiotics, okay? But most of the time it's sterile pancreatitis, so the role of antibiotics is doubtful. Should we do ERCP? Well, if it's a stone, small stone, and you think it's causing pancreatitis, it can be done. So you remove a small stone, do a papillotomy, and so the blockage should be relieved, and that will help. Surgery is indicated only if there's a complication. Otherwise, manage acute, but the lesson is manage acute pancreatitis conservatively. Conservatively mean fluids, analgesia, monitoring intake output, see if patient needs any NG tube, if the patient is vomiting, give them some nutrition, see if the patient needs an antibiotics, the severe pancreatitis, see if ERCP might be helpful, but no surgery, okay, unless patient develops some complication like an abscess formation, like a pseudocyst formation, and the patient is not getting better, then you start thinking about surgery. That's not an immediate option, okay? It's only when you develop some kind of complications. Next. Right. Lipase has a slightly higher, a few facts with higher evidence that lipase has slightly higher sensitivity and specificity and greater overall accuracy than serum amylase. But as I mentioned, this is not readily available. This is readily available, so you go ahead with that, okay? Ultrasound scan, I've already mentioned that the role of gallstone pancreatitis or biliary pancreatitis, you can see the stones in the gallbladder. You can also see common bile dilatation because of the stone at the lower end of the common bile duct causing obstruction. So ultrasound can give you information. Now the other thing is ultrasound finding should be examined in all patients with possible acute pancreatitis on admission. Okay, admission, do an ultrasound scan. CT scan, not necessary for the diagnosis, but if there's a doubt, diagnostic doubt, atypical presentation, there is asymptomatic hyperamylasemia or hyperlipidemia, then do. If the diagnosis is in doubt, do a CT scan, not routine. Okay, routine use of CT scan within 24 to 48 hours of admission only if there is some diagnostic doubt. Now, what are the different scoring systems? How you can say that this patient has got mild pancreatitis, this patient got severe pancreatitis. There are different scoring systems, but we are following this Glasgow scoring system in Pakistan. There are a Glasgow scoring system, then you have Ranson's criteria, the Ranson scoring system, and third is Apache scoring system. But we'll just time kya three, 4 minutes. Okay, we'll just quickly go that. So that's a scoring system. If you got more than 3, this is severe pancreatitis. If the 3 are positive, I mean 3 fits to that patient, up to 3 is mild pancreatitis. More than 3 is severe pancreatitis. Severe pancreatitis, patient needs to be in HDU, ITU. If they're less than 3, then the patient can stay in the ward and can be managed there. What are the factors? Age, white cell count, that goes up. Glucose goes up because the insulin goes down. Pancreatitis, urea goes up. Partial pressure of oxygen goes down. Calcium is utilized, so it's less than 2. Albumin is less. The LDL, lactic dehydrogenase, and liver transferases go up. So if they got 3, it's mild. If more than 3, then it's severe pancreatitis on the basis of scoring system. If you look at that, similar things on this side, Renson's criteria, but that's the one we follow. With few added differences like base deficit, and they also consider fluid sequestration more than 6 liters. Okay, and blood urea nitrogen. Next is Apache. Apache 2 is if you have in Canada, in America, they probably use this to score. It's called Apache 2 scoring system. It's acute physiology and chronic health evaluation. Okay, and as good as Branson's and Glasgow at 24. But Apache go more than 8 is severe acute pancreatitis, but you have to have a PC or a palm top uh, uh, formula to calculate that, and we don't have it here. So in North America and Canada, they probably use that. So what happens in Apache? What do we check? Body temperature, blood pressure, heart rate, respiratory rate, PO2, is arterial pH, plasma sodium, potassium, creatinine, PCV, white cell count, age, Glasgow Coma Scale, whatever 3 or more than 3, add that. So Apache takes into account the Glasgow Coma Scale as well. Okay, so there are 3 systems: Glasgow Coma Scale, this Ranson's criteria, and Apache 2 scoring system. Okay, so if there's a multiple factor scoring system to be used, the best choice at present appears to be Apache 2 calculated at 24 hours if you have the facilities available. Yes. And I think we'll just need 2. But now, what are the markers of this pancreas? Amylase, lipase, and the other thing is trypsinogen. And trypsinogen activation peptide called TAP. Okay, and CRP as well. You have TNF alpha, these are markers of inflammation, interleukin 6, 8, that cause cytokine mediator and discriminate severe from mild cases on day 1, right from the first day. They can tell you that this patient has severe pancreatitis or mild pancreatitis. C-reactive protein at the moment is most popular single test. Okay, I think we're getting to time. We'll see you later. Fiza, Tala, Ahmed, Hamna, and others. Hope to see you back soon. Pray, pray, and pray. Okay? Stay at home. All right. Okay. Goodbye. Bye bye. Thanks. Good. All done. Okay. Thank you. Talk, share. Any question? Question?
पूछना सर आपने कोई कोई
हाँ वो कुछ आया हुआ हाँ disconnect हो गया. There were a few questions. Yeah. No, sir. Thank you, sir. Yes, sir. We hear you, sir. Good morning, sir. Good morning. Okay. All right. Okay. Thanks.
आपने कोई सर पूछना
Okay. Stay home. Stay safe. Okay. Allah Hafiz. Take care.